Okay, well, thanks for joining me today. Today's webinar is on BioFlex personal therapy systems treating hip and knee pain. Once again, my name is Dr. David Kanashko. I'm a chiropractor. I've been practicing for close to 30 years, believe it or not. I'm the Director of Education, Research, and Training here at Meditech in Toronto, Ontario, Canada. A little bit of housekeeping before we get started. All my webinars are recorded, so that if you register and you don't have time to watch, you'll be sent a follow-up email within a week of the original broadcast that will have a link to watch it again whenever you wish as well. The purpose of these webinars, specifically on the personal therapy systems that we have, is geared towards non-clinicians. In other words, most people that use these systems are using them at home. They're not necessarily, a doctor or a chiropractor or a physiotherapist, although some may in fact be clinicians, and of course, they're welcome to watch as well. But I try to gear the information more towards the general public as opposed to someone that has perhaps a very strong background medically speaking. So today's topic is on knee pain and hip pain. And once again, if you haven't typed in your name and where you're from, and if you have a BioFlex system or you're interested or whatever, if you could be so kind as to do that, I'd really appreciate that. So I'm going to just, again, as I always do with these webinars, just briefly go over the system itself and a little bit about photobiomodulation. And then I'll get right into hip pain, the causes of hip pain, and how you would use a system to treat hip pain. Same thing for knee pain as well. And then I'll talk a bit about where to apply the pads and that kind of thing as well. And there's always a few safety concerns that we need to chat about when using the personal system. And then we'll have some time at the end for questions and answers. So if you have any questions, you can type them in as the webinar proceeds, and then I'll get to those questions at the very end, if that's okay. So we actually manufacture and sell two different systems, the BioFlex 120 and 180. The differences lie in the fact that the 180 has 180 diodes of light, whereas the 120 obviously has 120. The surface area is larger in the 180, and there's obviously more energy being emitted compared to the 120. The sizes are such that if you're treating large areas of the body, the 180 makes more sense, or if you're a larger person, as opposed to a smaller person or treating smaller areas, then the 120 would be more suitable choice. When you turn these arrays over, you'll see the diodes. They're actually by color, meaning that each of these diodes will emit red and near infrared light separately. And they're superluminous diodes. It's a hybrid LED and laser diode. So it's incoherent light, it's not specifically laser diodes, but they're a little bit more powerful, you might say, and more narrow bandwidth than LEDs. The controller unit, as I'm sure you're familiar with, is anatomically based. So you would choose the specific area of the body that you're treating and choose that protocol. If you're not sure what protocol to use, that kind of thing, you can always email me and I can help you out as well. So for obvious reasons, we're treating the hip and the knee today in this particular webinar. There are treatment stages from 1, 2, 3, and 4, and they represent increasing stimulation, both in the dosage of light, that is the intensity of light, and the pulsations of light coming out of the system. Excuse me. The physiological effects of laser therapy, or what's really known now as photobiomodulation, are many. They include increasing circulation by promoting angiogenesis, or the new growth of capillaries and capillary networks. It can have an impact on cells that secrete collagen, so it supports the integrity of the tissues. It can have an effect on muscle repair, regeneration, and muscle atrophy. It was really interesting. I read a review paper that talked about the use of photobiomodulation for muscular dystrophy. And there's really some really great science right now to indicate that it may be very helpful to include photobiomodulation in patients that have muscular dystrophy. It's of course not going to alter the course of progression, but it may slow down or help improve the symptoms of that particular disease. It has an effect on inflammation and swelling through white blood cells and the circulation. And it can also help promote the repair and the functioning of other cell types, including nerves, cartilage, and bone as well. There's two ways that light actually interacts with cells. One is directly. So if you have a damaged cell, it could be an injury, it could be a disease like osteoarthritis. The mitochondria, because of the inflammation, don't produce as much energy as they should, and sometimes these cells will either die or they will not be functioning very well. Their metabolism will slow down. If you do expose these cells to enough light, especially in the red and near infrared wavelengths, it can actually help the mitochondria become more efficient and stimulate them to produce more energy, and therefore the cell can recover more efficiently and quicker. There's also a very important effect called a systemic effect, and this effect is when you treat a large area of the body, the blood, or the bone marrow, although the bone marrow is more difficult to treat because it lies deep to cortical bone. But if you treat blood, specifically either red or near infrared light can stimulate immune cells like white blood cells and platelets. And when they're stimulated, the effects can be carried or mediated in the blood in and around the area of the injury or the disease, and it actually helps improve the metabolism and the repair of those cells that lie deeper. So, for example, if you're treating a knee joint, even though that light might not penetrate directly into the knee joint, you will get the indirect effects or systemic effects because you're stimulating the blood as well. Red and infrared light are used because of their effects specifically on mitochondria, and they penetrate in different ways. Red light penetrates more superficially, whereas near infrared light is a bit more transparent and can actually travel a little bit deeper. The depth of penetration ranges from a few millimeters to several centimeters when you get to near infrared. So red light, unfortunately, being absorbed by hemoglobin doesn't penetrate as deeper, whereas that near infrared light, being less absorbed by hemoglobin, can travel much deeper. It depends on the tissue, depends on skin color. There's lots of factors, but it's understood that near infrared light can penetrate several centimeters deep into the human body. The longer that you hold the light source on the tissues allows for light to actually accumulate and be more effective in the deeper areas of the body. So you'll see that when we treat, say, really large joints or deep areas like the hip, the device is on longer than if you're treating more superficial structures or areas of the body. Okay, so let's talk a bit about hip pain. And I want to mention that hip itself, being such a large joint and obviously a pretty complicated joint, and it lies very deep to musculature. So it's a very challenging joint to get directly light into the joint itself. So we're relying a lot on the systemic effects when you're treating around the hip joint to actually stimulate the deeper structures. The hip joint is a ball and socket joint, as you can see here. The ball of the femur rests in the acetabulum of the hip, and you can see there's ligaments that attach the ball directly into that socket. There's a labrum, which is a cartilage that also helps, forms a lip and helps that ball sort of be more stable in the actual socket. There's a very large capsule or ligaments that keep the ball and the socket together. You can see that there's an iliofemoral ligament and other forms of pubofemoral ligament that keep this joint firmly in place. It's very difficult to dislocate your hip, it usually takes quite a bit of trauma for that to happen, unlike the shoulder joint that can dislocate much easier because it's more of a shallow ball and socket joint. Lots of muscles surrounding the hip. On the rear or the back, as you well know, there's a gluteal muscles, gluteus maximus, medius, and minimus. And then deep to that, one of the most important muscles is the piriformis, which helps to rotate the hip. And then you can see there's other muscles here, the obturator muscles and femoral, quadratus femoris muscle. These muscles also help to control rotation of the hip joint. These deeper muscles, including the piriformis, is one of the sort of common causes of sciatica. And this diagram here shows you the innervation in the muscles in and around the deep areas of the hip joint. If you look in the front or the anterior, you can see there's hip flexors. These are the very top muscles that are actually attached to your hip itself, the ilium, as well as the lower lumbar vertebrae. These are known as the hip flexors. So when you lift your leg or your thigh straight up, these are the main muscles that are doing that. And then of course, everyone is familiar with the groin muscles or the adductor muscles. And these large muscles help to move the leg inwards. So think of when you're trying to squeeze your legs together kind of scenario, that's what the adductor muscles do. There are quite a few bursa. Bursa are fluid-filled sacs that decrease friction between moving parts. One of the most common conditions of the hip is trochanteric bursitis. And also occasionally you may also get ischial tuberosity bursitis or even gluteus medius bursitis as well. So when you're talking about hip pain, it may not just be in the hip. You may also feel pain in your thigh. It could be directly inside the hip joint or around the hip joint. You may feel pain in the groin or the adductor region or the buttocks. So that's all the areas that I've already talked about earlier. You also may have hip pain coming from the lower back or radiating from the groin. So you need to make sure that before you treat with the personal system, you probably should, and I highly recommend that you get a diagnosis so you know what you're treating. Because if you don't know what you're treating, you may not be effective with the equipment. Oftentimes, you may have reduced range of motion of your hip. Maybe you're limping. So these are all potential symptoms of hip pain. One of the most common causes of hip pain and discomfort, as everyone is aware, is osteoarthritis. The latest stats in the United States is 27 million people have hip pain related to osteoarthritis. Obviously, it's age-related oftentimes, but it may also be due to trauma or other factors. There could be joint cartilage deterioration. This may cause pain, oftentimes stiffness, and leading to loss of movement. When you look at the joint itself, there's degradation of the hyaline cartilage, and usually it takes a significant amount of deterioration before you start to feel discomfort. So by the time you start to feel hip pain and discomfort, oftentimes there's significant, usually 30, 40, 50% loss of cartilage. And unfortunately, that can't be really reversed to any great degree. You may be able to help support it, but it's important that on the very first signs of hip symptoms, don't ignore it. I would prefer that you would get an MRI or imaging to at least see the status of your joint so you know what you're dealing with. The trochanteric bursa is a fluid-filled sac that you can see here. It lies between the tendons of the gluteus maximus as it inserts into the femur and between the greater trochanter, which is a bony bump of your hip joint. So it lies between the tendon and the bone to actually decrease friction. And trochanteric bursitis will cause lateral hip pain, so pain on the outside of your hip because of inflammation. It may also cause degeneration of the soft tissues around that area as well. So generally speaking, when you feel this type of pain due to trochanteric bursitis, the pain will be on that outside of the hip where you feel that big bump or bulge, which is that greater trochanter of your hip. Tendinitis is a fairly common condition around the hip. Tendinitis is an inflammation of the tendon. It usually gets strained during activities, oftentimes during unusual movements or movements that you haven't done in a while. So for example, maybe during the COVID pandemic, you've decided to take up running or jogging or other kinds of activities you weren't doing before. You may develop a tendonitis because that tendon and that muscle group isn't used to that kind of movement, and you may develop these issues. Obviously, tendonitis is an inflammatory condition. This pain can lead to degeneration of the tendons, and that can lead to ongoing issues like tendinosis. May be present in the hip area itself, or the groin, or the hip flexors, or the gluteal tendons, or even the hamstrings. So the location of the tendonitis needs to be confirmed before you start to treat. Another fairly common condition is a hip labral tear. So the labrum is a lip of cartilage that surrounds the hip joint. It helps to keep that ball into the socket. So really what it does is try and keep the hip stable. Trauma is a very common cause of a labral tear. Repetitive motions, sometimes even hereditary conditions, can all lead to labral tears. These tend to be quite painful, and the pain oftentimes is very deep, and it's usually on the inside of the hip joint, in the front of the hip, sort of deep in the groin area. For this, you would need an MRI to get a specific diagnosis of the hip labral tear. Sometimes they'll do arthroscopic surgery to help to repair it, but if it's a minor tear, it can be helped with laser therapy, but cartilage heals very slowly, so the prognosis is a very slow healing process, and you should be aware of that. Another common cause of hip pain, of course, would be muscle strain. Muscle strain is basically just a tearing of muscle fibers, and they're usually graded from grade 1, 2, or 3, being mild to severe. Some of the most common strains or muscle strains around the hip area tend to be the groin area and the hamstring. So those are the ones that you'll commonly see. So obviously a groin pull or strain is going to create pain on the inside of the hip, whereas a hamstring is on the back, deep to the gluteal region or the back of the thigh. So where will you position the array for hip areas? Well, first of all, anatomically speaking, you need to identify the structures. So this bony bump on the outside of your hip, that's where the greater trochanter lies. And then you see there's a depression, and that depression is directly where the hip joint lies. And at the very top is the sort of bony bump of the hip, the iliac crest, called the anterior superior iliac spine. So you can see these bony landmarks are important to gauge where you might place the array depending on the condition. So make sure you know where the hip joint lies before you actually place the array over your hip itself. For an osteoarthritis condition or a labral condition, you want to treat all the way around the joint. Usually the first placement we recommend is in fact over the anterior joint, such that the midline of the array is overlying the midline of the joint. So you'll do that anteriorly, then you'll do it on the outside of the hip joint, laterally, and then the posterior aspect of the hip joint. Now make sure that these arrays aren't too far up or too far down, because then of course you're not getting the blood and the tissue directly over the overlying hip joint. For trochanteric bursitis, I usually recommend treating the area directly over the greater trochanter. So to find the greater trochanter, place your hands over your thigh, move your hips from side to side, and you'll feel this trochanter pushing out and that bump. It's usually obvious because if you have bursitis, it tends to be quite tender when you push in that area. So you can apply the array directly over the bursa. If you happen to be big boned or a larger person, you may need 2 placements over the bursa to ensure that you get good coverage over that bursitis area. For a groin or an adductor tendonitis, it's the sort of inner margins of your groin area that you're usually going to treat. So here I recommend 2 placements, or at least minimally 1 placement, but I prefer 2 placements overlying the adductor region. Sorry, I didn't actually mark it in here, but I'd like you to place 1 array over the top of the groin and then another array over the bottom of the groin. You can see this area is quite large, and there's lots of muscles here. So you want to get it as close to the pubic bone as possible and wrap the array around that area. And then just below that first placement, do your second placement overlying the adductor area. For hip flexor tendinitis, hip flexors, as I mentioned earlier, originate in the iliopsoas, so the muscles are coming from the hip and the lumbar spine, and they travel as a muscle belly in the front of your hip area. So you're going to place the array overlying that hip area. Again, you may need to do more than one array, and you may need to position it so that you ensure coverage to get over that entire hip flexor area. So one or two placements over the front of your leg, right at where this bump is, just above and just below is where I'd recommend placement. For hamstring tendinitis, oftentimes you'll have tenderness at the ischial tuberosity where these hamstrings connect. So for that, you'll feel just at the crease of your gluteal area, and if you push in, you'll feel a bony bump, and that's usually where you feel the hamstring tenderness because of hamstring tendinitis. So I'd like you to place an array directly over your lower gluteal region, and then just just inferior to that, a second placement. So you want to ensure you cover a good portion of the muscle belly and the tendon itself as it attaches to that bony bump of the ischial tuberosity. For gluteal tendinitis, remember that there's three gluteal muscles, gluteus medius, minimus, and maximus, and you can see that they tend to insert, the tendon inserts at that greater tubercle region. So this circle here shows you that general area, and you want to place an array, at least one, if not two arrays, directly over the side portion of the gluteal region to ensure coverage of the tendon itself and the muscle belly as it inserts into the tendon. Now, as far as treatment times go, every time you place the array over the hip, it's going to stay on for 20 minutes. So you can see that the time is quite long compared to some of the other areas, and that's because of the deep, thick muscles and how deep the hip joint itself is. So when you place the array, red light will first come on for 8 minutes, and then infrared light will come on for 12 minutes. So it will be a total of 20 minutes for each placement. Okay, on to knee pain. The structure of the knee, again, a fairly complicated joint. If you're looking at the bony and the joint structure, you can see that there's your kneecap or the patella, and then you see the femur, and it forms two what are called condyles or articulating surfaces with the meniscus, which is a cartilage attached to the shin bone or the tibia. So in fact, you'll have 1, 2, 3 joints that form the actual moving knee joint. So it's quite a complex joint. There, of course, are ligaments. The patellar ligament connects the patella or the kneecap to the bony bump of the tibial plateau. And of course, we have the meniscus on the inside of the knee, as well as attaching ligaments, the medial collateral ligament on the inside of the knee, and the lateral collateral ligament on the outside of the knee. At the very top, we have the patellar tendon, which attaches the quadriceps muscle into the top of your kneecap. Internally, you have two important ligaments called the posterior cruciate ligament, or the PCL, and the anterior cruciate ligament, referred to as the ACL. Lots of muscles around the knee. In the front, of course, is the quadriceps. Quadriceps meaning 4 muscle groups, including the rectus femoris, vastus, intermedius, lateralis, and medialis. On the back of the knee, you have the gastrocnemius, which is your big calf muscle attaching onto the inside of the knee, and then you have the hamstrings and some other muscles that attach in the back of the knee. There are many bursa, which are fluid-filled sacs, which makes sense because you have lots of movement at the knee. One of the most common areas for bursitis is the prepatella bursa that overlies the kneecap with the skin of the front of the knee. But there's other bursa as well. The popliteal bursa that causes Baker's cyst, and there's other bursa around the knee as well. So again, I highly recommend that you get a diagnosis, Sometimes it's obvious, like prepatellar bursitis is obvious. You have a big, a big swollen bump on where your kneecap is, and Baker's cyst, you have a big swollen bump on the back of the knee. But these other bursa are a little bit more tricky to figure out. So you may need imaging or at least someone to point out exactly what's going on there. The meniscus, there's two of them. There's an inside or medial, and there's which is on the inside of the knee, and there's a lateral meniscus. They form sort of little sort of shallow sockets, and they're fibrocartilage, and they're designed to aid in lubrication, shock absorption, and nutrition of the knee joint. One of the most common conditions of the knee that we treat in our clinic is, of course, osteoarthritis. Similar to the knee, you'll get degradation of the articular cartilage, and it's oftentimes you'll have to lose at least 30, 40, 50% of the cartilage before you start to notice symptoms. So oftentimes people are surprised when they've been diagnosed with knee osteoarthritis and they're told that it's quite severe, yet they say, well, I just started to feel symptoms. Unfortunately, it does take a long time of wear and tear, and the problem exists in the knee and you may not even be aware of it. So it's important to make sure you examine your knees, understand what's going on in your knees so you can be proactive. If you're above the age of 40, I would highly recommend that you do routine maintenance of the knee, even if it feels pretty good, because that will help slow down the progression of osteoarthritis. The bursa around the knee I already mentioned, but one of the most common causes of knee pain is prepatellar bursitis. So this is a swelling of the bursa in between the knee cap and the front of the skin. It's usually because you're on your knees a lot, maybe doing some tiling, maybe doing some gardening, that kind of thing. So whenever you do any work on your knees, please use proper cushioning to avoid that, because it only takes one event. Like you could just be doing gardening for one day, and then the next day you wake up and you have a big swollen mass in the front of your knee, and it's quite painful, and it's not a fun thing to have. So make sure that you're proactive and try and prevent this from happening. Baker's cyst is another common condition. It's a swelling of the popliteal bursa because of internal swelling and increased production of synovial fluid inside the knee. And this Baker's cyst oftentimes is painful and can restrict range of motion on the back of the knee. Patellar tendonitis, or jumper's knee, is a common condition of inflammation of the patellar tendon, or ligament actually, that connects between the kneecap and the tibial tubercle. Now, you don't have to be an athlete to get this injury. You could just all of a sudden go and start to do some walking or other activities that you're not used to doing and develop inflammation in the front of the knee. So if you feel or palpate your knee just below the kneecap and you feel that kind of hard sort of tendon structure, that's where you feel the pain due to patellar tendonitis. Meniscal tears are a very common condition. Many people think of meniscal tears during a sporting activity like soccer or, tennis or what have you, squash. However, in older people, by older I mean greater than 40, 50, 60, 70, 80, usually it's not caused by a traumatic event. It's usually caused by degeneration of the meniscus and normal everyday movement. So you could be squatting to reach something or moving your knee in certain ways. And because that meniscus is degenerated, you can start to cause little tears occurring in the meniscus. And before you know it, you start to have meniscal pain. Ligament sprains are usually caused by some kind of trauma, usually a bending or twisting of the knee when you're playing a sport or what have you. The most common ligaments that are injured are the medial collateral ligaments, so on the inside of your knee, or on the inside but outside of your knee, shown here. And they're graded from 1, 2, and 3. Grade 1 is a mild, and grade 3 is a complete tear. Grade 3 requires surgery. The anterior and posterior cruciate ligaments are directly inside the joint itself and usually caused by trauma, car accident, sporting event, that kind of thing. A mild tear of the ACL or PCL can be healed. A severe strain oftentimes requires, or sprain, oftentimes requires surgery. If you ever feel like you've had an ACL or PCL injury, make sure you get it diagnosed and treated right away, because without having surgery very quickly, it degrades inside the knee joint, and that will lead to complications as far as surgery. So you're best off to get it diagnosed, and if you need surgery, have it done quickly, because then you have a much better prognosis. So to position the array, I recommend that you place the array for treating osteoarthritis or a Baker's cyst or meniscal tear, inside sprains like ACL or PCL. You're going to treat the medial, lateral, and posterior aspects of the knee joint, so all the way around the knee joint. For medial collateral ligament sprain, usually you just need to treat them inside of the knee, directly over the middle area of the joint line. So here's the MCL, here's a joint line, and you want to place the array in the middle of that joint line so it overlies that medial collateral ligament. In larger knees, you can do 2 placements over this entire area. For patellar tendonitis, you'll want to place the array directly over the patellar tendon, or patellar ligament as it's sometimes called. So at the bottom of the kneecap, over the tibiotubercle, in between these areas is where you're going to wrap the array. Position it by strapping it into around the back of the knee. For pre-patellar bursitis, it's really obvious where you're going to treat. You're going to treat over this patellar region. I usually recommend placing the array over the swollen area, and that usually involves 2 placements over the patella and just beneath the patella to capture the entire swollen area. Baker's cyst, pretty obvious. I did mention it earlier, but what I usually recommend for Baker's cyst as well is not only to treat the back of the knee, but maybe do 2 placements if it's a large array. If it's a large Baker's cyst, do 2 placements over the entire back of the knee. And then I also want you to treat the front side, so the inside and the outside of the knee as well. So for Baker's cyst, you may have to do 4 placements around the entire knee joint. For the knee, the treatment times are about 14 minutes per placement, 6 minutes being red, 8 minutes being infrared. You should be using the personal system for an acute and initial injury at least 4 to 5 consecutive days, and then you can start to treat 3 to 4 times a week, so perhaps every other day, thereabouts. And then you can eventually start to treat 1 to 2 times per week as you're achieving fairly good recovery. Depending on the condition, like if it's a chronic condition like osteoarthritis, I do recommend that you do ongoing maintenance treatments to keep that knee as healthy as possible. That might be once a week or twice a week, depending on how it feels. These arrays are designed to make direct contact with the skin, so make sure that you removed any bandages, any supports, whatever you're going to put on the knee, take it all off. Make sure that you have direct contact with the skin. It should be in firm contact, so strap it around, not the elbow, but strap it around the knee in order to make really good contact. Oh, obviously I cut and pasted that statement. Sorry about that. So you want to allow the array to emit both red and the infrared light before moving to the next position. So remember, it automatically switches from red to infrared. Infrared is invisible, so you won't see it on, but you can see the timer on the device indicating that it's emitting energy. Try not to overlap the array excessively when you move it to the next position, and ensure that any oils, creams, or anything that you have on the skin is removed or wiped off before you're treating that area. So these systems are designed to emit high intensity, non-coherent light. They don't pose a risk to your eyes, so you don't need to be worried. If the array feels warm, so if you're using it consecutively, then just let it cool down for a few minutes, maybe 5-10 minutes before putting it on again. They should not be used, and I know we're doing the knee and the hip, but just so you're aware, they shouldn't be used around the lower back and pelvic regions during pregnancy. And you don't need to worry, there's no interaction with these wavelengths and photosensitive medication. These medications interact more so with ultraviolet light than they do with near infrared and red light. But again, if you're not sure, I would suggest you talk to your family doctor or the doctor prescribing in order to make sure everything's okay on that end of things. Don't use it over actively bleeding tissues, obviously over areas of known cancer as well. We are having a training tomorrow. If you're interested in attending our training, it's $199 Canadian to join us. Tomorrow it's all day from 9 a.m. to 4 p.m. If it's short notice for you, I'm doing another one on Friday, September the 18th as well. So you go to our website, bioflexlaser.com, to register if you haven't done so already. I really appreciate you taking the time today to listen to me. I very much appreciate that because I know everyone is busy nowadays. So I do have some questions. So if I may just get to those as well. There's a question about treating sacroiliac pain. Fran, I believed I covered that in my lower back webinar because today's was more on hip. But for sacroiliac pain, you know, we do have protocols for treating over that area, so it definitely can be helpful for that. I have a question. It says it comes with only one array. You keep talking about using two on larger joints. I don't see how you'd connect a second array to the system. So when I say to use two arrays, I'm talking about using one placement, then moving it to the next spot. So I'm not necessarily saying doing two at the same time. Unfortunately, the system, it does only come with one array that's connected. Our professional systems have systems that have up to 4 arrays going on at the same time, but obviously they're geared more towards clinical environment. As far as levels go, and I haven't really addressed that, but what I'd like everyone to do when you're treating these conditions is start with level 1. And then if you're making good progress, continue with level 1. If you've plateaued and things aren't improving after 3, 6, 9, whatever sessions, then move to the next level, second level, and then doing the same thing, waiting for improvement. Again, if no improvement, then move to the next particular level. I do have a question from Abhinav, and they say they're treating a client who had a history of a fall with swelling, no fractures. You know, Abhinav, I'm sorry, it looks like it's quite complicated. Do you mind emailing me? And by the way, my email is david@bioflexlaser.com. So if you have any questions, please email me. Abhinav, I'm gonna suggest you email me that information. I'll see if I can get an answer to you on that one. Can this be used for preventative treatment of osteoarthritis and degeneration of meniscus? I think I addressed that. It definitely can help to slow down the progression and as a preventative measure as well. So I would recommend that, you know, once you get to be of a certain age, or even as a young person, it certainly is helpful for blood flow and to keep any sort of degradation and slow it down. It's not going to stop it, but I think it can really help with the progression of osteoarthritis. There's lots of good research to indicate that, in fact, it does. Sorry, I'm just looking at more questions here. How many treatments would you recommend for slowing down progression? If you're using it on a maintenance basis, 1 to 2 times a week, I think would be my recommendation for helping being proactive or using it prophylactically. Has it ever been used for heterotopic ossification of hip after injury? Yeah, that's a good question. Ossification, you know, is due to stimulation of bone. It's not going to, so this therapy will help with inflammation. It will help repair bone, but the actual ossification process I don't know if it's going to do much for that specifically in that condition. I'm just not sure. I haven't come across that one. It's a good question, Selma. Previously, we were cautioned to avoid laser if the patient's taking photosensitive drugs. Okay, so whenever I've talked about photosensitive drugs, I said it's a precaution. I didn't say it was a contraindication. So by precaution, I mean, you want to be careful if these patients are taking, having this medication, that there's no interaction. But the research pretty much indicates that these drugs interact with ultraviolet light, not red and infrared light. So my standing on this is still the fact that you can still safely treat these patients, but just be aware that if there is any interaction, which should not happen, but if there is, then you just need to be wary of it. It's not going to cause any major problems. So I have a question from Pam, and she has, she says, every body part is timed at 14 minutes. This is different than my first unit in which treatment times varied. Could you clarify? Okay, so there were some modifications or adjustments to some of the protocols over the generations of the equipment that we were manufacturing. Some of that reflected in the changing of the energy densities that were used as well too. So regardless of what generation you have of the equipment, is designed to be effective for that specific body part. So if there's differences in later versions, it would have to do with altered energy density. So the actual dosage would be the same. So Pam, I don't think you need to be concerned necessarily that would have any undesirable effect or lack of efficacy for what you're doing. How could this efficacy be compared to an acupuncture laser pen? But question by Heidi. Okay, so laser acupuncture is designed to stimulate acupuncture points, but it's not photobiomodulation, because a laser pen usually is quite low powered, and it's meant to just do a very specific stimulation of that acupuncture point, but it's not going to create a systemic effect or even have a very profound photobiomodulation effect on the underlying tissue. So really, laser acupuncture is meant to stimulate acupuncture points, but not create a photobiomodulation effect on the underlying structures. Is there any evidence of laser over radio shockwave in terms of treating calcification? Well, that's a good point. So as far as calcification goes, shockwave works with ultrasonic sound waves, and it's meant to disrupt the tissues. Laser therapy actually would be a very good way of helping resolve that, the effects of shockwave. So I would use it synergistically for shockwave and then laser therapy. However, there's been research to compare shockwave and laser therapy head to head, not so much for calcification, but for other conditions. And typically laser therapy comes out as more effective than shockwave. Is it safe to use BioFlex laser class 3 at home, but treating with a class 4 laser at a chiropractor, or other way around? Yes, that's perfectly safe. So I have a professional mobile system and would like information re the probe. Kathleen, if you don't mind just emailing me, and I can certainly give you that information. Will this treatment help with sciatica? Absolutely. For sciatica, the issue here is you need to figure out what is causing that sciatica. Is it coming from the nerve root, herniated disc, piriformis, or what have you? Sciatica is not a diagnosis. It's more of symptoms related to a specific diagnosis. So it should help with sciatica for sure, but we'd have to understand what's causing the sciatica. Can the device be disinfected? Yes. So we recommend that you use a medical grade wipe, like a Sana wipe or any medical grade wipe in between use between patients, or even just between family members. Obviously with COVID and everything else, you want to make sure the actual array is always sterilized. I have a question about a sensation after treatment. if you do have an unusual sensation, that's a little unusual with respect to post-treatment. Sometimes people have a sensation because there's increased circulation. So that is temporary in nature and not necessarily anything to be concerned about. But if the array is heating up, then you need to let it cool down a bit. So I'm not quite sure what the scenario is there, Zaliba, but you can always email me if that hasn't answered your question. Thank you everyone very much for joining in. I do really appreciate your time. I do have another personal therapy system webinar next month. Just go to bioflexlaser.com and you'll see the events and the next webinars I have. Everyone have a great day, stay safe, and we will talk to you soon. Thank you.